Gupta. She is the well-known figure in our Uveitis practice, and really we are really happy to introduce her. She is a professor and chief of Department of Ophthalmology in Advanced Eye Centers, Postgraduate Institute of Medical Education and Research in Chandigarh, India. Our second speaker is Dr. Lilian Karina. She is a clinical assistant professor of ophthalmology, Eye Institute, Cleveland Clinic, Abu Dhabi. And we have Dr. Ahmed Salam, associate professor of ophthalmology, director, Uveitis service, and retina specialist, Jones Eye Institute, residency program director, Jones Eye Institute, director, clinical research, Jones Eye Institute, quality officer, ophthalmology services, Lyon University of Arkansas for medical science. We have as well Dr. Bara Al-Kubaisi, consultant cornea and uveitis at Eye Surgical Hospital, Damascus, Syria. And as well, we have Dr. Avinash Garbaksani, consultant ophthalmic surgeons in uveitis and medical retina diseases and cataract surgery, Moorfield Eye Hospital, Dubai, United Emirates. And we have actually our distinguished moderator, Dr. Fatma Ibrahim. She is head of ophthalmic department, chairperson, and member in service committee in Kasmi Hospital and Ministry of Health, national coordinator for eye health, preventive of blindness at United Emirates, Arab Emirates. And as well, we have Dr. Dr. Noura Al-Qasmi. She is a consultant ophthalmologist.
She apologized, Dr. Hassan. She apologized. She have some issue. She cannot join us.
It's okay. And finally, myself, I'm Hassan Al-Dibi, Chief of Uveitis in King Khalid Eye Specialist in Riyadh. Our program is really...
Also, Doctor, we have Dr. Igor and Dr. Iman. Also, we didn't mention.
Dr.
Igor.
I'm looking for her introductions. If you can introduce her, Dr. Iman, because I don't have her biography.
Okay. Sorry, just give me a second.
And Dr. Igor Gozak is a consultant ophthalmology specialist in vitreoretinal surgery, medical retina, and uveitis, Moorfield Eye Hospital Centers, Abu Dhabi in United Arab Emirates. So while we are waiting for Dr. Muhammad, I would like to give you just a little brief about our talks today. We have to talk about preventive vision loss in pediatric uveitis by Dr. Avinash, and we have preventive vision loss in non-infectious uveitis by Dr. Iman Abdellatif, and preventive vision loss in infectious uveitis by Professor Fishali Gupta. And optimizing investigations in uveitis patient by Dr. Lilian, management of macular edema in uveitis patient by Dr. Fahad Kohel, and optimizing cataract surgery in uveitis patient by Dr. Ahmed Salam. And finally, we have the masquerade syndromes approach by Dr. Bara Al-Kubaisi. So I would like to welcome all of you to start our sessions, and I would like to wish you to enjoy this distinguished talks.
Dr. Iman, she is Dr. Iman Abdellatif. She is a professor of ophthalmology, Alexandria University, and she is a uveitic specialist. Welcome, Dr. Iman.
Thank you very much.
I think Dr. Hassan, Dr. Fatma, you can now start with Dr. Bara, then up to you. I will take an excuse. Good luck.
Dr. Hassan, تفضل.
Yeah, the first talk will be going to be about clinical approach to masquerade syndrome, little bit the modifications in the program, as Dr. Al-Bara having some condition that to push him to leave earlier the session.
Okay, so should I start? Can you see my screen?
Yeah, it's clearly.
Okay. Okay. So I'm gonna be talking about clinical approach to masquerade syndromes. I have no financial disclosures. I hope at the end of this lecture that you will be able to understand some facts about masquerade syndromes, the classification, and there's a good paper that I found that I may point out some useful notes from, and I'll present a case, talk briefly about intraocular lymphoma, and we'll end with some learning points for clinical practice. So masquerade syndromes are a group of disorders that may mimic ocular inflammatory diseases. It was first described in 1967 by Theodore when he described a chronic conjunctivitis that turned out to be a conjunctival carcinoma. Some are benign, but whenever we use the term masquerade syndromes, we usually refer to malignant diseases. They're usually poorly responsive to steroids. They may happen in very young children or in elderly. And the importance of early diagnosis is not only for saving the eye, also we may save someone's life. Any delay in diagnosis or treatment can cause poor prognosis, especially with the new treatments available. The classification by etiology, we have neoplastic and non-neoplastic. Neoplastic, we have this list, and on top of that, we have intraocular lymphomas, a large list of non-malignant masquerade syndromes. I may mention intraocular foreign bodies, retinal detachment, and retinitis pigmentosa. There's a pediatric classification, and we have on top of the list retinoblastoma and Cott's disease. Some textbook photos of some malignant melanoma, leukemias, some ocular metastasis. So we don't usually see this classic presentation of retinitis pigmentosa. Sometimes we don't see the bone spicules or the arterial narrowing. So just keep in mind that we may not see these classic pictures. Also retinoblastoma. So this is a great paper. It's a retrospective observational case series of 828 patients who had uveitis. And it turned out that 40 of them had masquerade syndromes, and that's about 5%. About half of them had intraocular malignancies, and especially intraocular lymphoma. The eye doctor was the first one to recognize this malignant disease in over half of the cases, and usually it was in the older group of patients. And during follow-up, that was around 5 years, about half of the patients died. The most informative diagnostic procedure was getting fluid from the eye and doing cytologic analysis, and that yielded the best results for diagnosis of malignancies. Sometimes if a patient had a course of systemic steroids, so we can get negative cytologic results, and panuveitis was the most frequent manifestation. So this is my case, a 65-year-old Caucasian male complaining of blurred vision in the right eye for 1 month. It was getting gradually blurry, and he described a black veil in the center of his vision with some shimmering of lights. He had no eye pain, photopia, or redness. He was seen by a local ophthalmologist who treated him with steroids locally and systemically, and also he put him on an antiviral as he thought he may have herpetic iritis. He was also on moxifloxacin for recurrent sinus infection. Past ocular history, he had phaco done in both eyes, uncomplicated. His past medical and family history was insignificant. So when he came, his vision was 6 out of 10 in the right eye with no improvement on pinhole. Left eye was normal. Pressure is good. His anterior segment was quiet. We had no cells in the right eye, no KPs. Left eye was normal. Posterior segment, we'll see photos in a second, but he had some vitreous haze with no cells in the right eye. Left eye was good. So this is his fundus photo. As we see these small yellow round lesions in the right eye, nothing in the left eye. This is his red-free color photos, and the angiogram, we see these hypopigmented lesions. So we put a list of differential diagnosis. As this is unilateral, we thought of infectious, syphilis, TB, toxo, and autoimmune diseases like white dot syndromes, and we didn't forget the neoplastic. So we did this workup on him, and everything came out negative except for positive IgG for zoster and CMV. So the plan was keep him on antiviral and steroids and see how it goes. He came 2 weeks later with the worst vision despite the same treatment, and ocular exam was unchanged, so the plan was to perform a diagnostic vitrectomy. So interleukin 6 and 10 studies could not be performed because we had insufficient material. Cytology showed no malignancies or no malignant cells. The viruses, PCRs were all negative, but he had clonal pattern findings of IgA rearrangement by PCR that showed B cell population. So we diagnosed him with intraocular lymphoma. We sent him for systemic workup and everything came out negative except for the eye. So we started him with intravitreal methotrexate injections, and after first injection, the vision improved. Also, the lesions became smaller, so we gave him another injection. So here's the photo of his lesions. We can see they're getting smaller. So we continued 4 rounds of methotrexate injections, and we can see on the fundus photos that the lesions are almost gone. So he was doing fine, but 6 months later, he came with floaters and symptoms in his other eye. So the right eye was stable, but the left eye it showed some vitreous cells and haze. These are the photos. And we can see that the view in the left eye is not that clear. The angiogram, nothing important in the left eye. So we had a diagnostic vitrectomy, and this time cytopathology showed atypical cells. The interleukin 10 to 6 ratio was high, and clonal pattern findings of IgA rearrangement by PCR also showed B cell population. So we diagnosed him with lymphoma and started intravitreal methotrexate injections. A year later, he had widespread brain lymphoma, and he was continuing treatment with his neuro-oncologist with methotrexate. So briefly, I'll talk about intraocular lymphoma. It's a rare and highly malignant disease. It's easily misdiagnosed as uveitis. It's mostly B-cell in origin. It happens in elderly patients, females more than males, and it's almost always bilateral. We have primary and secondary classification. The primary usually arises in the eye and the brain, but the secondary comes from systemic lymphomas. The primary is usually in the retina, but the secondary is usually in the choroid. Clinical features, we can see a lot of vitreous haze, and despite that, usually the patient has good vision. We can see subretinal infiltrate. Other clinical features like any uveitis, but rarely we see cystoid macular edema. We can get the help of diagnostic procedures, as we saw in our case, the angiogram, and also OCT can show the subretinal infiltrates. So whenever we have any suspicion, we should get intraocular fluid and do analysis. And keep in mind that neoplastic cells are mainly CD20 positive cells. And this is important because we know that rituximab treatment is one of the new available treatments, and it's CD20, anti-CD20. We can also get high interleukin 10, or the ratio of high interleukin 10 to interleukin 6 is usually high. And just a quick reminder, the malignant cells produces interleukin 10, while the inflammatory cells produces interleukin 6. So whenever we have high interleukin 10, we should think of lymphoma. And as we saw in our case, IgH rearrangement can be helpful. So for the sake of time, we're not going to talk about treatment, but remember that methotrexate and Rituxan injections intravitreally are available treatments. The prognosis, whenever we have a brain lymphoma, it's usually poor. So some learning points for clinical practice. Any physician should have high suspicion whenever he had an elderly patient who has uveitis and is not responsive well to steroids. And whenever we have any suspicion, we should get fluid and send them for analysis.
So 1 minute.
So this is a picture, that shows, I'm done. This is a picture that shows that usually parents were concerned about their children sitting in front of the TV. And with the developing technology, everything is coming so closer. Thank you.
Thank you, Dr. Bara Kobaisi. It's a great presentations in tough subjects. I think we have to suspect masquerades in pediatric early ages of a set of possibility, as well the elderly age. I like the way that you presented the case, and actually the OCT is one of the key factors in diagnosing such reluctant cases to the management as a case of white dot syndrome. Any comments from the, or we can go to the second speaker, Dr. Fatma?
Can go to the second speaker.
Okay.
I have one question if there's time, or one comment.
Well, we are on. We can leave it to the end. Okay. Can you introduce second speaker, Dr. Fatma?
Okay, I can. I will ask Dr. Abimah to give his talk. It will be in preventive vision loss in the pediatric uveitis.
Thank you. I will. Thank you for this opportunity to present this very important topic, preventing vision loss in pediatric uveitis. Why do children lose vision, with uveitis? Well, there are three reasons. One is the complications of the disease. There are the complications of the treatments and amblyopia. And I always say to the parents that, you must fear the complications of the disease because they are more severe and unpredictable. The complications of the treatment are predictable, and we can deal with that as and when we encounter that. So in today's day and age, we shouldn't really be seeing this. This is a child I saw about a month or month and a half back, presenting with a 6-month history of uveitis and coming to me with bilateral cataract, posterior synechiae, with a vision of 660 in the right eye and counting fingers in the left eye. So this is really unfortunate that this child was not referred earlier. And, seeing a child at this stage, really, that the rest of the life of this child is going to be affected by vision issues. Whereas if we had seen this child earlier, things may have been different. So complications of the disease here, we see, you'll see cataract, glaucoma, and band keratopathy. And when you look at the historically, this paper from London, they showed that the blindness rates really changed significantly from early days to the beginning of this century. So patients should not really be losing vision, especially as the treatment has changed. So the blindness rates would have been, in 30 to 40%, but that should really go down to 6 to 10% now with better treatments available. Again, cataract, glaucoma, and band keratopathy are the three main things that we see. So the goal of treatment should be to limit complications in order to ensure long-term visual stability. And I say to parents that it is their responsibility and my responsibility to ensure that this child that we see will be able to see well as an adult as well. Remember, you have to talk to the parents and convince them. They're often the barrier. The child is the easy part, actually. Remember to examine the child as a whole, not just the AC. Determine the pressure. Now it's much easier with the eye care non-contact tonometer. Check for a cataract. Always perform fundus exam, and if you can't do it by clinical exam, Optos is a very useful tool. Remember the amblyopia, and occasionally you may need to do EUA, but I really haven't had that need for years and years, and always also involve the pediatrician. This is a multidisciplinary subject with I involve a pediatric ophthalmologist, the pediatrician, the pediatric rheumatologist as well. So preventing vision loss due to the disease cannot be, the hallmark of this is adopting an early and aggressive use of immunomodulation. And that is basically the summary of this talk, is early and aggressive use of immunomodulatory agents. Parents will hear the words immune modulation, especially now with COVID. Oh, no, I don't want to give my children immune suppressions, they'll get COVID. And that really hasn't changed anything. Blindness is far worse than getting a little bit of COVID. Do not wait for complications. As the child that I showed you, coming with bilateral cataract, do not wait for complication. Early and aggressive. Ensure frequent visits. You have to say to the family that they have to come again and again. Yes, holistic overall growth and education, etc., has to be taken into consideration. You have to explain to the family that recurrences are inevitable, and these are long-term cases. In the we can extrapolate. This is the JIA algorithm, but we can extrapolate it for most uveitis. And topical steroids should only be used for very mild cases and for a short period. But if you find that things are not coming under control, you really need to get a grip on things. Jumping through these hoops very quickly to going from to methotrexate early and then to biologics may be required sooner rather than later. And when you look at the impact of this of uveitis in adults, this changed rapidly. 1990 was considered a pivotal point when rheumatologists became much more aggressive with treating pediatric uveitis and JIA with methotrexate mainly. And it's really changed the amount of, you can see, this is basically patients who got no vision impairment or blindness by the time they were 18 or 22 or 30. And you can see that patients before 1990 really had far too many complications, whereas after 1990, when the use of methotrexate became standard practice and early, then that made a big difference. Glaucoma, again, treat early. I'm not worried about glaucoma so much because, I would give children anti-IOP lowering medication much early, even sometimes prophylactic. Kids are, known to be steroid responder. Avoid alpha-GAN in children, they don't tolerate it. But all other drops, including prostaglandin inhibitors, can be used. Treat the inflammation and the IOP will come down. Sometimes when you see the patient acutely, the pressure may be low and there will be a rebound. And remember, if you treat aggressive and early, you will prevent this long-term hypotension, which is, again, a very difficult disease to deal with. Band keratopathy, again, this is indication of a long-term disease and it may limit the visual recovery. So even though you're treating the uveitis, you may end up with amblyopia if you haven't considered treating the band keratopathy. So always keep that in mind. Complications of the treatment. Well, we know the local complications, mainly cataract and glaucoma coming from the steroids, and some of the systemic treatment also coming from steroids and from systemic immunosuppression. When you see the medication used here in this idiopathic uveitis groups, ocular complications, again, cataract and glaucoma and posterior synecdoche seem to be more prevalent. And here you see in the this is the sort of groups between, in this study where they looked at idiopathic and JIA uveitis. But topical steroid use was seen in 90% of the patients. And a lot of them had quite a bit of steroids hourly, 6 times a day. So this is quite a lot of steroids. Not much intraocular steroid use in this group. Systemic steroids in 94% of the patients, and long-term steroids in nearly 40 patients. So steroid use is still quite prevalent in patients with idiopathic uveitis. We know that patients with treated on steroids really don't do very well. And, we're all familiar with Jennifer Thorne's study showing that, you must try and get it down to less than 3 drops a day to prevent these complications. Oral steroids are used very rarely and only for a very short period. And, yes, in adults, it's very well tolerated, but they should have no place in pediatric uveitis except for a very short period. And, we should use non-corticosteroid treatment. Methotrexate, fantastic drug, been around from 1948 or 1958, but there is no RCT, but efficacy has been very, very well established. Parents, of course, first thing they ask you as soon as you get control is when can we stop it? And I keep trying to say that it's a minimum 2-year deal. So methotrexate, whether it's idiopathic uveitis or JIA uveitis, seems to be the #1 drug used, and that's very useful. I also use mycophenolate in kids, and it's again pretty well tolerated, especially if you can get the syrup version. Anti-TNFs seem to have also very good evidence, and of course we know that through the Sycamore study, adalimumab is a licensed anti-TNF. Other drugs are also used and can be used.
1 minute, please.
And I believe that we should adopt the change in this treatment strategy. So instead of the step ladder approach, going bit by bit, we accumulate collateral damage. And so we should use the elevator approach. And if the first line doesn't work, quickly move to biologics. Remember the refraction and amblyopia. Always get refraction checked every few months. And remember the amblyopia management. Early and aggressive use of immunomodulatory agents is extremely important. Do not wait for complications. So pediatric uveitis is a sight-threatening disease, but it need not be. It has high rate of complications. However, did I say this before? Early and aggressive therapy, it can ensure long-term visual stability. Thank you.
Thank you, Dr. Avinash, for a very valuable lecture. We'd like to hear more about this in future, inshallah. And now I'd like to invite Dr. Iman Abdel Fattah to give her talk in preventing vision loss in the non-infectious uveitis. Dr. Iman.
Thank you very much. Thank you very much, Doctor. It's always a pleasure to be with you and with Professor Dr. Mohammed Al-Amay and with all my colleagues and professors and attendants. I shall share with you today a few clinical tips which I hope would help our colleagues in establishing a better visual outcome for their patients, especially in non-infectious uveitis. I have no conflict of interest in any of the material hereby presented. And in this coming few minutes, I shall focus on dealing with uveitis in female patients, which in our countries might not be getting the same privilege of male patients in some regions. I'll speak first about pregnancy. The specific immune system or the delayed immune system has 2 sides, 2 wings, the cell-mediated immunity and the antibody-mediated immunity. In pregnancy, there is an immunologic bias towards the antibody-mediated immunity because the fetal MHC major histocompatibility complex coming from the father will initiate rejection by the cell-mediated immunity of the mother. So deliberately, the cell-mediated immunity of the mother is decreased, and in order to protect her from infections, the antibody-mediated immunity is increased to compensate for that. This decrease and increase in these 2 types of specific immunity apply whether to health and disease. So they apply to the proper immunity and to the autoimmune diseases. We shall see in a moment how this applies to a clinical practice every day. First, we would like to give a hint about how this depression of cell-mediated immunity during pregnancy occurs. 3 hormones are produced by the fetus, namely the placenta, which suppress this cell-mediated immunity: the progesterone, the corticotrophin-releasing hormone, and the melanocyte-stimulating hormone. These 3 hormones increase steadily throughout pregnancy, and unfortunately, they drop abruptly after delivery, because when the placenta is delivered, no more hormones are available for the mother. Plus prolactin, if she breastfeeds, will increase after delivery, which is an inflammatory hormone. This hormone increases the tendency of the body to get into inflammation. And this is one clinical tip, especially for the junior colleagues attending with us. Sometimes you get referred patients who went to several of competent and very well able colleagues, but she did not respond to any therapy. So usually we have 4 or 5 problem areas we look into if this type of patient is a female, and another 4 or 5 problem areas to look into if this type of patient is a male. In a female, take care of the female who is not responding to any therapy by any colleague, that he might have hyperprolactinemia. Because if the prolactin hormone in this female, this lady, by the way, in which this part of the printout of the lab is taken, is one of my patients, and who is not lactating even. She has a tumor in the brain which is producing extra prolactin. This high prolactin is an inflammatory hormone, a potent inflammatory hormone, and she will not respond to any therapy, no matter what you give her, unless this prolactin is decreased. This is just on the side. Now, 3 important results for the introduction we have given in your clinical practice. We said that the cell-mediated immunity in pregnancy is suppressed by virtue of the 3 hormones we have just mentioned. This applies both to health and disease. So the cell-mediated autoimmune diseases, that is to say the autoimmune diseases resulting from a problem with the cell-mediated system, like rheumatoid arthritis, multiple sclerosis, Behçet's disease, and all these, improve during pregnancy, whether you give them treatment or not. So the problem is that these diseases and the ocular manifestations resulting from them will relapse in the immediate postpartum period because of the withdrawal of the hormones suppressing the faulty cell-mediated immunity. So a pregnant female must deliver. We cannot prevent delivery, but we should advise her against becoming pregnant if she has one of these diseases. So if you have a patient with scleritis, uveitis, optic neuritis, with the cause being a cell-mediated autoimmune disease, please advise her not to enter into marriage and pregnancy unless she is very well controlled, because she will relapse in the immediate postpartum period. If she happens to have become pregnant and delivered, advise her against breastfeeding, because prolactin will increase and will make the control of these diseases extremely difficult. On the other hand, the antibody-mediated immunity will increase during pregnancy in order to compensate for the suppression of the cell-mediated immunity, and hence the other half of autoimmune diseases that result from problems with the antibody mediated part of the delayed immune system will relapse during pregnancy, in contrast to the other one. The cell-mediated autoimmune diseases improve during pregnancy but relapse after delivery. But the antibody-mediated diseases relapse during pregnancy. Hence, these patients, especially those with systemic lupus, should not become pregnant unless very well controlled. She will lose the kidney, and she will lose the lungs and the eye, and very important organs if she becomes pregnant with an uncontrolled disease. Third application is that the intracellular pathogens are eliminated in our bodies using the cell-mediated immunity. And this applies to viruses and protozoa. And because the cell-mediated immunity of the pregnant female is suppressed, she cannot get rid of these pathogens. So infectious uveitis due to toxoplasmosis, HIV, herpes zoster will relapse during pregnancy, because these changes, which we have covered early in the presentation, will cause a very aggressive course of infectious uveitis caused by these agents in pregnant women. And this is the first tip I'd like to give our dear attendants in preventing vision loss in non-infectious uveitis. Women with a history of uveitis should be monitored closely during pregnancy and during the postpartum period. And now the second tip I'd like to give you is that this hormonal effect on the uveitis and the ocular inflammation in general is applicable to all females, not necessarily the pregnant sector. In a similar manner to what we have just covered, cell-mediated uveitis relapses during the second half of the menstrual cycle due to withdrawal of the anti-inflammatory or the immune suppressive female hormones. Now, I shall illustrate this in a better way. This is the menstrual cycle. We shall see that in the 4th week, there is a progesterone drop. This week is extremely dangerous to withdraw your treatment through it. And this is why I do not advise any of my colleagues to deal with a female with uveitis or ocular inflammation and withdraw treatment and increase treatment and exert changes in the treatment plan without asking her where she is in her menstrual cycle. She is not like a male. She is she undergoes the dramatic and effective changes in her hormones all the month. So please, if she is in the 4th week, do not withdraw treatment. The best way, the best time to withdraw treatment is in the first half of the cycle where the hormones are relatively stable. Quickly about the treatment of uveitis in pregnancy, the FDA classified the drugs into 4 groups. Group A is the safest, but there are not many drugs in this category because it says no risk in controlled studies on humans, and this is not available for now. Group B, human data, said no risk, but there are no controlled studies. The studies available are lower evidence studies. Group C, no human data, animal risk proven. Group D, human risk proven. Considering the medications you give during pregnancy, cycloplexus are considered safe. However, topical steroids have been associated with animal congenital anomalies, so please limit them to the least effective dose. The non-steroidals are sometimes used in uveitis, but they are more with ocular wall inflammation, scleritis and episcleritis. Take care if the female is suffering from delayed conception, not to give oral non-steroidals because they inhibit ovulation and further lengthen the period of infertility. If necessary, they should be limited to the 1st and 2nd trimesters. After the 20th gestational week, they impair the fetal kidney function, and after the 32nd gestational week, they are absolutely contraindicated. If she is breastfeeding, please avoid diclofenac, whether diclofenac sodium or potassium. Ibuprofen and endomethacin are considered better options. Oral steroids, I'll go quickly through the repeated information. And I will focus on a kind of unique piece of information which you might not find it everywhere. Apart from the problems to the mother and the fetus, please take care that steroids pass from the mother to the fetus, so the fetus will be immune suppressed. And at least
yes, it's gone.
Okay, thank you very much. And at least in my country, a large part of the compulsory vaccination program are live attenuated vaccine. For example, we use the oral live attenuated polio vaccine. So we have to be very close to the mother during the postpartum period and tell her not to give the child live attenuated vaccines unless he recovers from the immune suppression. One last clinical tip I'd like to tell you that there are many classifications of steroids. The one which has the most clinical significance, in my opinion, is whether it is fluorinated or not fluorinated. Dexamethasone is a fluorinated steroid, while prednisolone is an unfluorinated one. The fluorine atom prevents the inactivation of the steroid molecule by an enzyme in the placenta known as placental 11 dehydrogenase. So the dexamethasone will pass from the mother to the fetus active, and the prednisolone will be inactivated. So when you want the systemic steroid you give to the mother to reach the fetus, give her dexamethasone. This is very broad without many detail for the sake of time. But when you want the systemic steroid not to reach the fetus, give her prednisolone. Don't forget that if you are giving the pregnant mother systemic steroids, you should give her stress doses of hydrocortisone during delivery. Breastfeeding prednisolone is safer, but if the dose, the daily dose is beyond 40 milligram per day, 4 hours spacing between it and between the lactation is advised. This is kind of a funny thing to finish with or to conclude with the presentation, is that we have seen previously that the FDA classified the drugs into A and B and C and D categories. Yeah, I hope you find it funny that the methotrexate is class X, which is very far from the first 4 letters, because it's extremely teratogenic. So the FDA put it in a separate class. Only methotrexate is in class X, and there are no E or F or G or any letters in the middle. Both the father and the mother should not be on methotrexate at least 4 months before conception. I'm sorry for maybe exceeding my time slot, and thank you very much for your courtesy and hospitality.
Thank you, Dr. Iman, for this presentation. Now I'd like to introduce Dr. Vishal Gupta to give her talk on the preventive vision loss and the infectious uveitis.
Dr. Iman, you have to stop sharing.
Sure, doctor.
Thank you very much. At the outset, I would like to thank Professor Amri and Middle Eastern Ophthalmological Society. It's a great pleasure to see all the friends back once again. So I'm going to talk about infective uveitis. So let's see what actually causes visual loss in infective uveitis. 1, we fail to recognize the phenotype. So what we do is we just tend to treat everything with corticosteroids, and that could result in the disease progression. And secondly, like Avinash put it beautifully, is that sometimes we fail to recognize the complications of the disease. And when we talk of the posterior uveitis, sometimes we just fail to recognize whether it is the reactivation of uveitis or it is the complication. So I will show you the examples. Now look at this patient. It's a young 25-year-old lady, and she has lost her fovea. So you can say that this is the posterior uveitis, which has caused a debilitating visual loss. Why? Because the patient was diagnosed as TB choroiditis elsewhere, given anti-TB drugs, given steroids, received topical, oral, injections and everything. And if you look at the phenotype clearly, it's not truly a choroiditis. There is much more to it. So these were some of the investigations which were nothing significant. We did the diagnostic vitrectomy because honestly, I did not know what we were dealing with. And we found that the vitreous shows the cyst of the toxo, and also the IgG from the serum was positive. That's not the point. The point is what led to the visual loss. Now, this is the picture she was carrying all along before, when she presented for the first time. So she brings the picture. She says, long time ago, this is how the disease started, and I could get this picture. Now look at the disease. The disease was very typically retinitis, as you can see from this lesion. And the disease was amenable to therapy, but somehow we failed to recognize it as retinitis. Somebody labeled it as choroiditis, started steroids, ATT probably did not matter, but steroids caused a lot of worsening. And what we did was the toxo, which was so beautifully amenable to therapy, we resulted in this kind of visual loss. So that is the first point to learn, that if you are dealing with uveitis, please try to recognize what phenotype it is, because between this and this, there is a vision loss. The second part, which I said, sometimes it's not a disease which is recurring, it's the complication of the disease. And honestly, we forget that disease can cause complications. We fail to recognize, and we keep on pushing in more steroids, more immunosuppression, because we think that it is the disease, it is the infection which is recurring. Now, here is an example of patient with TB serpiginous like choroiditis. So she's treated, she's healed, but she says, now I have complaints of metamorphopsia. So, you know, in a busy clinic, I looked at her eye, I said, no, there's nothing, it's all healed. But patient was persistent and she said, okay, I said, let's get an angiogram done. So we got an angiogram done, and you see there is an arrowhead, but this we saw in retrospect, because in choroiditis, there is so much going on that in angiogram, honestly, if you show me, I would say probably nothing much is happening. However, never ever ignore patients' complaint. So we did OCT. OCT showed a shrimp, which could be kind of subretinal hyperreflective material. You can think it's just a scar, but patient has symptoms. So when we did OCT angio, we realized that beneath this, there was a new vascular complex, which probably was not producing fluid as yet, but which was causing metamorphopsia. So we treated her with intravitreal ranibizumab, and her vision improved from 624 to 69. You can see here the change in the character of the new vessels. And still, you know, at that time, it doesn't happen to me now, I wasn't very sure that this truly is the new vascularization. So we prolonged the gap and we went up to the 14 weeks. So you can see the new vascular complex increasing again and patient complaining of metamorphopsia again. So this is the lesson we need to learn, that sometimes the patients with posterior uveitis may come with the visual loss, and that visual loss may not be due to the primary disease, but it could be just due to the complication of the disease. And this can definitely be prevented if one carefully learns to identify these complications or sequelae of the disease, and learn to differentiate between the recurrence of the disease versus the development of any complication, because the treatment for the two may be entirely very different, and it may save central fine visual acuity to the patient, especially if it's a choroidal neovascular membrane. The third lesson is my third case. Now, this is an interesting 32-year-old man again, who was actually diagnosed as CSR elsewhere and was referred to us to see what it is. It was the right eye that was affected. Vision is 624, no inflammation in the anterior segment. And when we looked at this, so you can see, well, it could be CSR, nothing against it. And there is something yellowish here, which could be fibrin in CSR again. So we did the OCT. The OCT line scan, you can see passing through the fluid showed a serous retinal detachment, which looks like CSR. But then as you go here through that yellow material, you see there is hyperreflectivity, and you see this membrane, which is these days, you know, we are chasing it a lot. It's called basilar membrane. So if you see this basilar membrane kind of a detachment, it is more likely to be infective, inflammatory, I meant, and not non-inflammatory. Anyways, so the question is, was it central serous retinopathy? And as I pointed out early, because of that membrane and because of this particular configuration, we thought it was more likely to be uveitis than CSR. So we did the fluorescein angiogram, and the fluorescein shows some hypofluorescence. And, in the later phase also, nothing much was happening. But if you go to the later phase, there was pooling of the dye in the spaces. Now, it did not show any point leak or smokestack, which we would expect in CSR. So we know that this is the one which is probably inflammatory pathology. And ICG very well showed that this was at the level of the choroid, and this was hypo, remaining hypo, which means something was happening in the choroid. So we had points both in favor of CSC and not in favor of CSC. I won't go over these points. I will show you the course. So we did the test. Her TB skin test, which is Monteus, was strongly positive. It was 13 into 13. Quantiferon was negative and chest was normal. So, we thought we were dealing with tubercular choroiditis, so it was not very, very typical, but still, because of the OCT features and ICG, so we thought it was TB choroiditis. In the meantime, patient received oral steroids and the lesion started healing. And within 1 month, you realize the vision was back to normal, no ATT given. Patient was very happy. He says, I'm doing fine. And anyways, we also thought only one test was positive. So maybe we can get away with it. So patient was all right, but he comes back 2 years later. Now you see what happens 2 years later. There is again that fluid which is accumulated, and there is this yellowish kind of a granuloma. And as you see, the choroid is kind of elevated like you would expect in granuloma. Fluorescein ICG again showed there was the involvement of the choroid, and the late phase of ICG shows this hypolesions, which is very typically seen in choroidal involvement. And you see the late phase fluorescein and ICG. So this time we plan for intravitreal anti-VEGF injection because TB granulomas in our experience are all VEGF driven and they respond very well to intravitreal ranibizumab besides giving systemic therapy. And this is the follow-up after 3 months, and now we have 2 years follow-up on the same patient, and he's doing very well, and we are able to preserve the visual loss because we are able to get his fovea back to normal. So what lesson we learn from here? What we learn is the recognition of the phenotype. It's very important. Like in this patient, we knew we were dealing with TB, but somehow, we were on the borderline. But it is still very important that if you initiate this specific treatment in time, you can prevent the progression of the lesion. Like I would say we were lucky that he had a recurrence after 2 years, which we could manage and preserve his vision. But we have a number of patients of serpiginous-like choroiditis who are just treated with immunosuppression, steroids, no test for TB. And then we see them after 2 years, 3 years, landing up with TB abscess, when it becomes very difficult to maintain the vision or the preservation. So these are the 3 points I wanted to highlight. Learn to recognize the phenotype very clearly, whether it is retinitis, whether it is choroiditis, the etiologies for 2 may be very different. Look at the patient as a whole. Learn to recognize the complications from the disease activity. And the third and the last thing is, if you have any infection which is coming out to be positive, be ready to treat with the specific therapy, because specific therapy is extremely important to prevent recurrences. And if you are able to prevent recurrences in posterior uveitis, you will be able to preserve vision in these patients. Thank you very much.
Thank you, Dr. Gupta. Dr. Hassan?
Dr. Hassan, you are muted. I think he's speaking, but he's muted. Yeah.
Yes, I will go for next speaker, Dr. Lillian, and she will talk about optimizing investigation in uveitis patients. Dr. Lillian?
Thank you so much. Let me start sharing the screen. So thank you so much for this kind invitation. I hope in the next 15 minutes I will be able to help you better understanding the importance of a proper and tailored workup in patients with uveitis, and mostly to help you choosing the best test in order to apply those results in the single patient management. If I show you here these 4 patients, all of them, they have uveitis. But I think it's not easy from only the pictures to say which is the diagnosis. Wait a minute. So I don't think it's only from the pictures easy to guess the diagnosis. And that is why we need ancillary tests in uveitis management. So the question is, do we always need ancillary tests? And I think the answer is yes. In most of the cases we will need. Is exceptional that we are not going to need ancillary tests for these patients. And then do we need a standard battery of tests? And if the answer is yes, which ones are the tests we are going to choose? And keep in mind at this point that you have to balance between the cost of the test and the benefit of the obtained results, since these tests are usually expensive and they are not always available in every single healthcare facility. So in order to answer this question between the need of a standard group of tests or just a non-standardized approach, we have this paper here. It's called the ULIS study, and they compare a standardized 3-step approach to an open strategy allowing the ophthalmologist to request any type of investigation. In the standardized group, the ophthalmology was able to request only CBC and differential sedimentation rate, C-reactive protein, a tuberculin skin test, syphilis serology, and chest radiography. And in the other one, of course, it was an open strategy. At 6 months, the rate of etiologic diagnosis was comparable between both strategies, the standardized or the open one. This means you have to select your test, and there isn't a standardized approach where you just click all the box and ask for the test. So complementary examinations in uveitis should be carried out to complete the ophthalmologic and clinical picture, and they should be guided by the pre-test probability of finding the etiology. This is our main goal with the ancillary test, the ophthalmologic signs and symptoms, and the therapeutic consequences. We should ask tests that are going to influence in our therapeutic management. And we have blood investigations, radiologic investigations, invasive non-ocular investigations, and of course, invasive ocular investigations through intraocular samples. So let's go through all of them. First of all, the complementary blood examinations, and this is by far the most common ancillary test we are using in our patients. Erythrocyte sedimentation rate and C-reactive protein are very simple tests to be ordered, and even though they are highly non-specific, I still find them very useful in the management of patients with uveitis. For example, the elevated sedimentation rate can predict the development of uveitis in children with juvenile idiopathic arthritis. And any uveitis with highly elevated sedimentation rate and or CRP is very likely to be associated to an underlying systemic disease. And this is in my practice very useful because I can think about a specific diagnosis of uveitis associated with these systemic diseases. Very interesting, if you are facing a case of uveitis of unknown origin, and the only thing you have is elevated sedimentation rate and anything else, and you cannot link this uveitis to any systemic disease, you should think about HIV positivity. In HIV patients, they have hypergamma-globulinemia because of the infection, of the chronic infection, and in these cases, a sedimentation rate is elevated. What about lymphopenia? Lymphopenia is important as it can predict the diagnosis of sarcoidosis. You know, sarcoidosis is not usually very straightforward diagnosis, and we need several tools to get the proper diagnosis in most of the cases. Of course, ACE and lysosome are very important for the diagnosis of sarcoidosis, although in clinical practice, they are not always positive or in high values. Serum levels of IL-2 receptor also point towards the diagnosis of ocular sarcoidosis. This test is not available everywhere and it's highly expensive. And for the presumptive diagnosis of tuberculosis uveitis, in many countries, you still have the TST, tuberculin skin test. We do not have that here in Abu Dhabi. But this test has a very important role mainly in countries where BCG vaccination is not practiced. It is not expensive, and if you can access to it, I found it very useful in the diagnosis of tuberculosis uveitis. Also, energy for the tuberculin skin test is important because it can orient our diagnosis towards sarcoidosis. Many times the two clinical pictures, they overlap. The quantiferon test and the other test related for the immunoglobulin release assays have a role in the diagnosis of tuberculosis uveitis despite vaccination status, and this is very useful in countries where vaccinations is mandatory. The anti-nuclear antibody test I found useful only for the diagnosis of juvenile idiopathic arthritis associated uveitis. This is a very non-specific test, and it will become positive in many clinical settings without giving you a clear orientation towards your diagnosis unless you are dealing with a suspicion of juvenile idiopathic arthritis associated uveitis. Serology still is very useful, although the utility is becoming lower with the more extended use of ocular samples testing, as I will show you later. Still, for me, Toxoplasma serology is useful, not because I want to get the diagnosis should be clinical, but sometimes they refer a patient with only a scar and you explain to the patient that this is a scar from tuberculosis. So it's useful to get the antibodies, because if the IgG is negative, well, this is not a case of toxoplasmosis. Of course, we need to order HLA, but we need to order HLA typing in two different scenarios. The first is HLA-B27 spectrum of uveitis. And in this case, HLA-B27 positivity, of course, is linked to the diagnosis. We need this to be positive to arrive to the diagnosis. In case of HLA-B51 in the setting of Behçet disease, I just remind you that it's not part of the diagnostic criteria, although the positivity will increase the likelihood of the diagnosis. And many times HLA-B27 spectrum and Behçet disease, the clinical picture overlaps. So many times I order them together. Vitamin D and ocular inflammation. This is something quite new for us to be ordering and very interesting. First of all, deficient in vitamin D is neither necessary nor sufficient for ocular inflammation to occur. And there is no uveitis that is just related to low levels of vitamin D, or there's no uveitis that will be treated only by vitamin D supplement. supplementation. However, there is a growing body of evidence linking vitamin D to ocular inflammation. For example, active cases of non-infectious uveitis, they show lower serum vitamin D levels in comparison to non-active counterparts or non-uveitis counterparts. Also, in juvenile idiopathic arthritis patients with normal vitamin D, there is less likelihood to develop uveitis. This is a very recent paper, and it's quite interesting because they study vitamin D levels in cases of definite, presumed, or probable sarcoidosis. Again, it's difficult many times to get to the diagnosis of ocular sarcoidosis, and they found that in patients with sarcoidosis, the median serum levels of vitamin D was lower. And even more interesting, they had a higher median serum levels of 125 dihydroxy vitamin D, which is a different, we have in blood circulation two forms of the vitamin, the 25 and the 1.25. So in these patients, the 1.25 was higher. And the ratio between the 1.25 and the 25 was always higher. And this form of vitamin D, 1.25, can be actually synthesized in activated macrophages. So a median ratio more than 3.5 was associated in this cohort of uveitis with the diagnosis of sarcoidosis. So the question is, should we order this measurement of serum vitamin D levels in our patients with uveitis? My answer will be yes, but only the 25 form of vitamin D, and this should be followed by supplementation if needed in any case of non-infectious uveitis. The other, the 1.25, is only an investigational surrogate screen for the presence of granuloma forming disorders and should be applied with caution because it's very new information we have. Now let's move to ocular specimens, and the first one is the conjunctival biopsy. This is not something we practice very frequently, at least here in the UAE. However, if you have the chance to discover these small yellowish translucent subconjunctival nodules, which, excuse me, oops, how can I go here? Which are present in 7 to 17% of sarcoidosis cases with ocular involvement. If you can take them for a biopsy, your diagnosis will be very straightforward. They are infrequent. They are more frequent in patients who are younger than 35 years old, and the rates of positivity of this biopsy in sarcoidosis patients with or without uveitis varies from 27 to 55%. Among the ocular specimens, it is my opinion that aqueous humor is the one with more results in managing patients with uveitis. I usually take my aqueous humor samples under surgical microscope and through an aseptic technique, although there are colleagues that can do this at the slit lamp. But keep in mind that for most of the analysis we want to carry out, we need between 100 and 200 microliters, and this will not be very easy to achieve in the slit lamp without the risk of having a forward movement of the lens iris diaphragm. This is a very safety procedure. The only risk is the effraction of the anterior capsule of the lens during the procedure. That's why it's better not to perform it under pupil dilation. When you have your sample, you can proceed in 3 different pathways, depends on your suspicion. Most of the time we will go for microbiological examination of the aqueous humor. PCR, mainly for the diagnosis of viral infection, although we can use this for bacteria and parasites. And also keep in mind, you can find intraocular antibody production through aqueous humor analysis. Cytological examination is very important in the diagnosis of intraocular malignancies, but you need a very specific laboratory, and this laboratory has to be very close to your facility because the sample needs to be transferred quickly. And you can do cytology for malignant cells and flow cytometry. For cytokines analysis is not only for research purposes, but also it's very useful in clinical practice, the measurement of IL-10 levels for the early detection of primary intraocular lymphoma. This is just to give you an idea that in most of the infections, aqueous humor or vitreous are equal as stairs to be analyzed. And PCR is mostly the technique we are using, although for some parasites like Toxocara and for rubella and some cases of toxoplasma, as I will show you in the next slide, we prefer the Goldman-Whitmer coefficient. So in ocular toxoplasmosis, and whenever the clinical diagnosis is not straightforward, if you have small lesions in immunocompetent host and you are going to analyze the aqueous humor, the Goldman-Whitmer coefficient will be of more value than the PCR. And the opposite will happen if you are dealing with a large lesion and you have an immunosuppressed host. What about the diagnosis of Mycobacterium tuberculosis? You know, sometimes it's very difficult when the clinical picture is not very clear to get the diagnosis of tuberculosis-associated uveitis. And the aqueous humor positivity will depend on the clinical picture. In cases of granulomatous panuveitis, you can find 66% of positivity in the samples, and this will go down to 33% of positivity in cases of retinal vasculitis. So will depend on your clinical picture mainly. It's important to keep in mind that whenever we are not sure about the diagnosis, we should go to aqueous humor analysis in different series. This analysis carried out on aqueous humor resulted in changes to the therapeutic management in 13 to 40% of patients. This is just to show you the first paper about the measurement of IL-10 in aqueous humor. This was done in France, and this is still very useful, although the definite diagnosis is the biopsy. And this is the place for diagnostic vitrectomy. MEL is the reference technique for the diagnosis of intraocular lymphoma, and it's also very useful for infectious uveitis, mainly in the management of, in the diagnosis of tuberculosis.
1 minute, please.
So the retinochoroidal biopsy is our last step for the diagnosis of primary intraocular lymphoma. Very quickly, thoracic scans are useful in the diagnosis of pulmonary sarcoidosis and less in cases of TB. MRI to rule out multiple sclerosis in cases of intermediate uveitis. I use in every single patient before starting anti-TNF alpha therapy. And whenever we are suspecting that there is a central nervous system involvement in the setting of uveitis, for example, in Behçet disease. Biopsy of minor salivary gland is useful in some patients with sarcoidosis, although it's not very common to be practiced. Same as bronchial fibroscopy and bronchoalveolar lavage, also for sarcoidosis. And the lumbar puncture and cerebrospinal fluid analysis, we use this in multiple sclerosis, primary intraocular lymphoma, and VKH disease. PET scan is less used for us as uveitis specialists, but is important in patients with unexplained uveitis or uveitis of sarcoid appearance. And finally, Keep in mind to guide your etiological assessment by clinical and epidemiological data. Keep in mind the resources of the healthcare system you are working in, and orient your diagnostic workup towards investigations for common diseases or diseases whose diagnosis may have therapeutic consequences. And good luck, because many times, even with all the things we have, we cannot get the proper diagnosis till the disease is advanced. Thank you so much.
Thank you, Dr. Eliane. It's very nice, but the time is very short. Sorry for that. Now, now I would like to introduce Dr. Fahad Tohin to give his talk in management of the macular edema and uveitis patient. Nora. Dr. Fahad, with us or not?
I think Dr. Fatma, Dr. Amri was saying that Dr. Fahd might not be joining or joining late.
Okay, Dr. Ahmed, you can go ahead with your presentation, please.
Sure.
Yeah.
Or Dr. Fahd is here.
Oh, that's great.
Just to remind the audience, the indications for steroid implant within the European Union, Ozurdex is indicated for inflammation of the posterior segment of the eye, presenting as a non-infectious uveitis, and Iluvien is indicated for the prevention of relapse and recurrent non-infectious uveitis affecting the posterior segment of the eye. I want to illustrate what I've discussed so far with some various case scenarios that I faced in my practice. The first is a 54-year-old female with intermediate uveitis with cystoid macular edema affecting her right eye. There was no fellow eye involvement, vision is 6/24 on the right, 6/5 on the left, with a mild posterior subcapsular lens opacity in that right eye. She had a workup to exclude infectious causes, and no underlying systemic cause was found. Just to remind everybody of the template that I showed earlier, because she's unilateral, she has moderate to severe macular edema, we went down the intravitreal steroid route, and particularly because she had a cataract, I felt comfortable to do that. So she's an older patient with a lens opacity, with unilateral uveitis, without systemic disease, and she's treated with intravitreal Ozurdex. This was repeated 4 to 6 months later because of cystoid macular edema recurrence. On both occasions, it gets an excellent visual and anatomical response. However, to prevent relapse of her ocular inflammation, the patient was treated with Iluvien 8 to 10 weeks later, after the second Ozurdex injection, and macular edema was well controlled for the last 12 to 18 months. So this is now a 2 to 3 year history, and she's now developed a visually significant cataract, and she's currently awaiting right cataract surgery. Case scenario 2. This is a 65-year-old gentleman presented with bilateral vitritis, anterior uveitis, with subclinical macular edema. And what I mean by that is that his macular thickness is above 300, but there's with global orange on his macular volume or his macular thickness map, but there's no intraretinal cyst, there's no subretinal fluid. He's got widespread retinal vasculitis on his fluorescein, vision is 6/6, and his main issue is the floaters. I've diagnosed him with birdshot chorioretinopathy. He's HLA-29 positive, infection screen is negative. So going back to this pathway, he's non-infectious, he's bilateral. My first line is systemic steroid. Because he's birdshot, I'm expecting him to recur or relapse, and it's going to be chronic, so I add in a second line mycophenolate. But because he's got a clear crystalline lens, I avoided giving him a systemic steroid implant. Sorry, an intravitreal steroid implant. So he's commenced on 16 milligrams of oral steroid. I tapered this down to 7.5 milligrams over a few months. I don't want to keep him on high dose steroid long term. I start him concurrently on mycophenolate mofetil, which I gradually increased to a maximum daily dose of 3 grams a day. He has a bit of improvement in his vitritis with a one-step improvement, but there's no reduction in his macular volume or central macular thickness. But I'm not panicking. His vision is still 6/6. but the patient's best subjective visual improvement was when his steroids were more than 30 milligrams a day. He's really not happy being on 7.5 milligrams of prednisolone or 3 grams of mycophenolate. But I said to him, look, it's only floaters, your vision is still good, your macular edema is stable, let's see how you go for another 3 months. I see him 3 to 4 months later, his vision is still 6.6. Patient, however, not happy with his quality of vision. It's not as good as when I started him on high-dose oral steroid. I review his OCTs again, and his macular volume and his central macular thickness has progressively become worse in both eyes, despite, in my mind, good and decent immunosuppression. There's no intraretinal cyst or subretinal fluid. However, he's been on systemic medication for a good 6 months. I've given it a real good chance. I'm not keen to increase his systemic steroid. He's got clear crystalline lens. I'm really not keen to give local steroid implant. Now, you've got to realize this was before COVID. With COVID, I think maybe I would have broken the rule here. However, this was pre-COVID, so I add in adalimumab injections, and over time, his OCT actually gradually dries with subjective vision improvement. So he's always remained 6.6, but the floaters are better, but the edema is improving, and it takes 4 to 6 months to reach this endpoint. But I've got a satisfied patient who's actually heavily immunosuppressed. But like I said to you, I never considered steroid implants because he had bilateral disease and clear crystalline lenses. But it'd be interesting how I would have managed this patient during the COVID era. I probably would have gone for local steroid injections in the first instance, given his age. Case scenario 3. This is a 74-year-old female, bilateral ear disease with cystoid macular edema. Vision is 660 in the right eye, 680 in the left. She's quantiferon TB positive. I jointly managed her with infectious diseases. She started on oral steroid with anti-TB medication. She's a bilateral pseudofake. So again, looking at my pathway, because it's bilateral disease, I decided to give a systemic steroid. I don't expect there to be TB in the eye, but she has systemic anti-TB treatment. Oral steroids are gradually tapered to about 5 milligrams. Vision is improved to 612 right, 69 left. Because it's bilateral disease, I add in mycophenolate, which I increased down up to 2 grams a day. But she didn't tolerate it very well. She's getting a lot of gastrointestinal symptoms, so I switched to myfortic acid, 720 milligrams twice a day. She still doesn't tolerate this, so I reduce it to 360 milligrams twice a day. But to be honest with you, she's not even happy being on this amount of medication. She develops ankle edema and water retention whilst on steroid. So even on 5 milligrams of steroid, she's getting side effects. So I reduce her dose of steroid. However, her uveitis is inactive. It's well controlled. There's no anterior chamber inflammation now. There's no vitreous inflammation with only mild macular edema, uveitic macular edema bilaterally. A tiny intraretinal cyst in both eyes, CMT 320 microns, something like that. She's pseudophakic, so let's just give her Iluvian straight away to prevent further relapse, to give her good long-term control of her uveitic macular edema. But it's a quiet eye. I feel comfortable that Iluvian will work well in this case. I stop her mycophenolate. I reduce her oral steroid to 2.5 milligrams a day. I didn't want to take her off steroid completely. And her vision remains excellent at 6966 level with good UMO control at 18 months with no interventions required up until this point. And then lastly, case scenario 4, 65-year-old with bilateral retinal vasculitis. He's got bilateral uveitic macular edema on initial presentation. Vision is 618 in the right eye, 69 in the left eye. Bilateral pseudofake. Just to share with the audience, I've had a similar case like this post-COVID. Bilateral pseudofake, retinal vasculitis with UMO, with no infections. And this lady we've managed locally with bilateral Ozurdex. And if she gets edema recurring again, I will give her another Ozurdex and treat her with Iluvian long term and avoid systemic medication entirely. And the patient wants to do that she cares for her grandchildren and doesn't want to have to shield, which is what she would have to do if I started her on systemic immunosuppression. And shielding is a very severe form of self-isolation where not only does she have to remain in her house, but she would have to isolate from other members in that household. And particularly with this lady, she wanted to avoid that should a second wave of coronavirus appear. And it looks like in the UK, unfortunately, in the next month or so, a second wave of coronavirus is on its way. So, it was an eventuality. But that's a separate case. But I'm just going back. But going back to this case, this gentleman had, unfortunately, previous herpes simplex keratitis in the right eye, with HSV detected on the corneal swab 2 years earlier. So because he's bilateral and this was pre-COVID, and he's had an infection in one eye, I go for the systemic option. He started on high-dose oral steroid. He's concurrently commenced on mycophenolate 3 grams a day. This was kind of in autumn of 2019. He's tolerates the steroid and MMF well. The macular edema in the left eye is completely resolved, but the humour in the right eye is improving, but not fully resolved. I'll review him 3 months later. His vision is 612 on the right, 69 on the left, and after 6 months of treatment, his UMO is still more than 350 in the right eye with persistent central intraretinal cyst, and his vision hasn't improved to my liking. His left macula is still dry, macular thickness is less than 300, and as I said, in normal circumstances, like in that other lady, I would have considered an intravitreal steroid implant to treat this unilateral persistent of macular edema in his right eye, particularly because the left eye is doing so well on the concoction of systemic treatment. However, he's had previous herpes simplex.
No? Yes, I think because we are running out of time, if you could move to Dr. Ahmed Salam, because our limited time to 6:30. So, Dr. Ahmed, could you help us and get in?
Thank you so much, Dr. Hassan, for the introduction. My talk is on cataract surgery in uveitis. I apologize. Give me just 1 second. I've lost the Zoom screen. Okay. So, Dr. Hassan, can you see my presentation screen?
Yes, I can see, but can you put it in the no presentation mode?
Yes.
Yes, good.
Okay. So thank you so much. So I'll be talking about.
I think your presentation presentation mode is
Okay, I'm sorry. I apologize. One second. Sorry.
Yeah, because this is presenter mode.
Yes, I don't know why it's doing that. Let me share screen.
It's okay. I think so. All of us.
Okay, we're good now?
Good, excellent.
We're good now, right?
Yes.
Okay, so I don't have any financial disclosure. I just want to tell the audience about the difficulties encountered during cataract surgery, and also talk a little bit about the surgery tips as regarding pupillary dilatation. But more important is the preparation and the mindset for doing uveitic cataract surgery. There are issues that need to be considered very thoughtfully before the surgery, which include what level of inflammation, also the intraocular pressure and the visual potential of this eye. I'll give you an example. If patients have hypotony that is persistent before cataract surgery, that may get worse, and hypotony for uveitis cases is really unfortunately is the end of the game, especially when it's chronic hypotony. So that's something to reconsider whether the patient is going to benefit from the surgery as well. The question is, can cataract surgery activate uveitis, for example, toxoplasmosis or herpes simplex virus? For toxoplasmosis is doubtful. There was some evidence from old literature at the time of extracapsular cataract surgery from Dr. Ruthova's group that showed that it's 30% activation after extracapsular cataract surgery of toxoplasma. We don't see this with phacoemulsification, and we don't use prophylactic measure. Herpes simplex virus, we usually give these patients prophylactic treatment, acyclovir, 1 day before the surgery and do 14 days more. That's coming from the herpetic eye disease study or like from some of the results of the study. Very, very special consideration for GIA, because these patients, they need to be really very quiet, and there are special consideration for them, whether you put IOL or not. And the general feeling is that if they're young, don't put IOL. For older patients who are well controlled, yes, you may put an intraocular lens in. Then on the same theme really is, okay, we read in textbooks about zero tolerance for inflammation before cataract surgery. Is that the case? Yes and no. Yes, you want zero tolerance, but in many patients you cannot reach to no inflammation. So you want to operate on the patients when you think this is the maximum or control of inflammation you're going to get for this patient. This is, like, for example, if this is your patient, you had this patient for many years, you know, this is the best, like, you know, trace cells, this is the best, then that's the time to operate. Again, we talked about GIA and special considerations. So what are the options of treatment to cover the surgery? So these patients are controlled on their anti-inflammatory medications, and let's focus more on non-infectious uveitis. So what else to do? You need to cover the surgery. Surgery is still inflammatory, so you need to cover the surgery. So all patients will get high-dose topical steroids. After the surgery, you may start a day or so before or a week before, which is fine. There are other options as well: orbital fluoroquinolone, systemic, oral or intravenous prednisolone, and then intravitreal steroids. So the question we usually ask, okay, what are you going to give to these patients? So if there has been CME in the past, or there's concurrent CME, or there was a diagnosis of panuveitis in the past, then really methods of orbital fluor or subtenon quinolone, that's too soft. And we will go for systemic or intravitreal. Usually, I prefer intravitreal unless the patient has had documented steroid hypertensive response. And sometimes in single-eyed patients, I'll be a little slightly worried of putting intravitreal in them, so then I would use systemic steroids. But remember, if patients had more of a hardcore uveitis, surgery has to be covered by anti-inflammatory medications, and orbital fluor injections are not enough. But for those who did not have that, then you can do, yes, topical steroid and orbital fluor injections or subtenon steroids. We talked about the infection, and, you know, toxoplasma, we don't cover it for phacoemulsification. I apologize, something happened. I'm sorry, my presentation shattered. Yeah, I was going to show you the video. Let me actually, I can play it from here. Is time still okay, or?
Well, the time is already, we are past.
We're past.
Yeah, because we have now the company symposium.
Okay, all right. I'm sorry. Let me just finish maybe in 1 minute. I'll say here, you know, the important point is the preoperative control, and that needs to be tight. Then you can manage the pupillary with removal of membranes and Malaysian ring, and put in a single piece acrylic, and be very thorough with cortex removal. Post-operative, very important to look for cystoid macular edema. All right. I think I've been slightly disadvantaged being at the end.
Yeah, thank you. It's really, and it was an important, part of uveitis, that to do cataract surgery in this patient, how to control the inflammation perioperatively, and post-operatively. But inshallah, in another meeting, we can see this video now that you are
Okay,
running.
if you have time. I mean, I don't want to be really. I think the important point is removing pupillary membrane. Then I tend to use Malaysian ring. Cataract surgery in uveitis removal, the cataract itself is not a big deal. Usually all these cases, or most of them, are very soft cataract, so it's not a big deal. I tend to bring it in the antechamber and remove it. The other important point is to be very thorough with cortical removal, and I would polish, and I spend a long time cleaning, and I would remove all the lens matter. And then remove the malugal. Here in this case, I gave Ozurdex as well. So you want to put that before removing the viscoelastic with the IFER. And this is an important point here. I just want to show at the end is you want to keep the AC deep at all times. So for example, here before coming out with the irrigation at the end, I would wait and hydrate the wound and make sure the AC stays deep to prevent collapse of the antechamber. Thank you so much.
Thank you, Dr. Ahmed. It's really a great, impressive, and practical and informative talks that from all the speakers. I would like to thank you all for this opportunity to be together. I would like to thank our virtual attendee of the sessions and wish to see you again in reality. Thank you all. Thank you, Dr. Fatma. Thank you, Dr. Igor, for you really to be moderator of these sessions.
Thank you.
Thank you, Dr. Ahmed. Thank you, everyone, for this session. And now we will go for company symposium. Thank you very much.
Thank you.